Hello, everybody, and a very good afternoon to all of you. I hope you're all doing well. I'm hoping the previous three videos of image based questions were useful for you people. I want you all to go through those videos first so that you can score yourself and evaluate yourself so that you know where you are standing. Right? So, after doing that, I'll be starting with the lectures of each topic one by one. So today's lecture is one of the most basic things in orthodontics, that is Andrew's 6 keys of normal occlusion. Okay, this is something which you all must have done multiple times during your BDS and you must be thorough with it. Okay, but revising it time and again is very important because this is one thing which you take into consideration while doing the patients. Okay, and you should know it basically. So here starts with your revision lectures. So the first key the Andrew came up with was based on few of his findings. Okay, so Andrews' key were given by Lawrence F. Andrews. In 1972, Andrews studied 120 orthodontic models. Okay, he went through the study models of 120 patients and we saw there was absolutely normal occlusion, good intercuspation, and everything was very much normal. It looked very well. Aesthetics was good. There was no spacing. There was good intercuspation. Occlusion was normal, and everything was good. So he wanted that all his patients should have end results in a similar manner. Okay, even all his patients' final cast should look like this in a normal occlusion. Therefore, what he did is he studied those casts, those models very properly, very thoroughly. He collected 120 such casts which were of patients who were non-orthodontically treated and they had an excellent occlusion. So he studied what was something which led to such a good occlusion. So based on that, he came up with certain keys. See, if we follow these keys, we can achieve good occlusion in all the patients. Okay, doing treatment is one thing and getting a stable aesthetic occlusion is other thing, right? So that is what we aim, a stable occlusion, stable outcome. So the first key which he gave is molar interarch relationship. Now all of you must be knowing what is class 1 molar, class 2 molar and class 3 molar. Okay, so knowing it properly is very important. Identification of molar relation is very important. Each and every criteria has to be kept in mind. So the first thing he told that this molar relationship should be absolutely tight and the contact should be very well. According to Andrews, the mesio-buccal cusp of the upper first molar should occlude in this groove. Okay, this was the first thing he told. Next, what he told is that the mesiolingual cusp, the cusp which is present on the lingual surface mesially, that is the mesiolingual cusp, should occlude in the central pit or the central fossa of mandibular first molar. Mesiobuccal cusp is in this groove. Mesiolingual cusp is in your central fossa, central pit. Right. The third thing which he told was that the distal marginal ridge of upper first molar. Can you appreciate this distal marginal ridge? So this distal marginal ridge should occlude with the mesial marginal ridge of lower second molar. Okay, so these were 3 to 4 things which he highlighted. He said for a molar to be in a good class 1 intercuspation, the mesiobuccal cusp of upper first molar should lie into the groove of lower first molar. The mesiolingual cusp should be in the central fossa and your distal marginal ridge should occlude with the mesial marginal ridge of lower second molar, right? So this was the first key given by Andrews, that is molar relationship. The next thing which he told was mesio-distal crown angulation, right? This is a very important key, so please listen to the explanation of these keys very carefully. According to Andrew, mesio-distal crown angulation is the angulation which is formed by a line drawn perpendicular to the occlusal plane. So this line which is drawn perpendicular to the occlusal plane and the angulation which you get is mesio-distal crown angulation. So what he did, he made a line which is along the long axis of the crown. Okay, so it is known as LAC, a long axis of crown. So a line is drawn through the long axis of the crown. So and then that line is drawn perpendicular to the occlusal plane. So this angulation which you get is your mesiodistal crown angulation. So now for teeth to be in good occlusion, for good intercuspation, the crown portion, okay, please note that the crown portion should be mesial as compared to the gingival portion. When long axis is drawn, when long axis of the crown is drawn, the crown portion should be mesial as compared to the gingival portion. So all of you can see this angulation, the lines are not straight, they are tilted this way. Why? Because the crown portion is more mesial as compared to the gingival portion. What is mesial? Mesial is closer to the midline. So if this is my midline, if I check this distance and this distance, obviously this distance is less, indicating that the crown portion is closer as compared to the gingival portion. So you have to draw a line along the long axis of the crown. So when you draw a line along the long axis of the crown portion, the line which is representing the crown portion should be more mesial as compared to the gingival line, okay, which is very much evident from this horizontal distance. Therefore, this line is drawn perpendicular to the occlusal plane, and this is the angulation which is covered, right? So this is the second key given by Andrews, which is known as mesiodistal crown angulation, which is defined as the angulation made by a line drawn perpendicular to the occlusal plane. So if this is the line which is drawn perpendicular to the occlusal plane, this is the occlusal plane, this is the line which is drawn perpendicular to it, and the angulation which you get is your mesiodistal crown angulation, right? I hope it is clear. Sorry. Now the next key given by Andrews is labiolingual crown inclination. First was mesiodistal crown angulation, right? Now this is inclination, which is also known as torque. Okay, when you do your masters, or maybe you all have heard of terminologies like tip and torque. So labiolingual crown inclination is known as torque. Again, now what is done here? This is the occlusal plane. This line is representing the occlusal plane, and this is a perpendicular drop onto the occlusal plane. See, 90 degrees. So this is the perpendicular dropped through the occlusal plane. Now what do you see when the crown is closer to this line as compared to the root or the gingival portion? That represents a positive crown inclination, right? So my crown is, or my tooth is said to have a positive inclination when the crown portion of the tooth is more labial as compared to the root portion or the gingival portion. Understood? If my crown is labial as compared to the gingival portion, it is a case of positive inclination. Whereas if my crown is more lingually inclined and my roots are buccally placed, it is said to have a negative inclination. So all teeth in the dental arch have different inclinations, right? So if you have understood this concept, you can see that my upper anterior teeth, they have positive inclination. They have a positive torque value. Positive torque value means my crown is more labial as compared to the gingival portion. So even if you measure the horizontal distance here, horizontal distance is less. Okay, the crown portion has less of horizontal distance as compared to the gingival portion. Why? Because this is more labially placed as compared to the gingival portion. So it is said to have a positive torque. Now if you imagine this situation of lower posterior teeth, my lower posterior teeth have a negative inclination. Why and how? See, I'm drawing this line touching the gingival and the crown portion. What do you see? That my crowns are lingually rolled in, or they are lingually placed as compared to my roots, which are more prominent in the buccal region. Even if you see your own occlusion, what do you find? That the roots of the lower posterior teeth are prominent. and your lower posterior crowns are lingually placed. Okay, so that is your labiolingual crown inclination. All teeth have different inclinations. If they have proper inclination, that is upper plus minus both, right? Few teeth have positive inclinations, few have negative. Only then they can intercuspate very well. Only then the occlusion will be very much normal and intercuspation would be really good, right? So that is how your inclination varies in arch from tooth to tooth depending upon the crown and the root, which is buccally placed, what is more lingually placed or buccally placed. So that is known as your labiolingual crown inclination, which can be positive or it can be negative. Upper anterior teeth have positive inclination because the crowns are more labially placed as compared to the gingival portion, whereas your lower posterior teeth, lower posterior teeth, they have a negative inclination because my lower teeth, the crowns of the lower teeth are lingually inclined, right? So this was the third key of occlusion given by Andrews. Moving on to the fourth key, absence of rotation. Andrews said in order to have a good occlusion, a normal occlusion, there should be no tooth in the dental arch which is rotated. Okay, no tooth should be rotated. Only then we can get normal tight intercuspation and good occlusion. Okay, now one thing to note here is if we consider a case of rotated upper central incisor as seen in this figure. In this figure, what do you see? That your 2-1 is rotated. Okay, so when an anterior tooth is rotated and when we derotate it, when we need to do orthodontic treatment to derotate that tooth, we need space. Okay, so therefore to derotate an anterior tooth, upper anterior tooth, space is required in the dental arch. First you need to create space and then derotate this tooth. Why? This is because the mesio-distal width of upper anterior tooth is more than the labiolingual width, right? So therefore an upper rotated tooth occupies less space in the arch and you need space to correct that rotation, right? Moving on, and let us see the next situation. If we have a rotated posterior tooth, for example, if we have a rotated premolar, okay, and if we want to derotate it, so after we correct the derotation, what happens? We get space in the arch. Okay, so correction of a rotated premolar gives us space, whereas to correct an upper central incisor, to correct a rotated upper central incisor, we need space in the arch. Okay, now moving on, let me explain you this situation. This is very important. I want you to understand this very well. See what happens in premolar. The mesio-distal width of the premolar is less than the labiolingual width. Because the mesio-distal width, in this case, my mesio-distal width is less than the labiolingual width. So when the mesio-distal width is less, and when we correct the rotation, we get space in the arch, right? I hope it is clear. Absence of rotation is one of the key features to have a good and normal occlusion. An upper anterior teeth needs space to correct the rotation, whereas a posterior tooth, for example, premolar, gives us space when it gets corrected, all because of difference in the mesio-distal and labiolingual width. Upper central incisor has more mesio-distal width is more, right? It is thick this way, and labiolingual width is very less. So if it is rotated, it is fine, it is rotated. So when we want to derotate it, we need space. Okay, so to correct this kind of occlusion, we need space. Okay, we are needing space, and after correction of this, we get space. Okay, space is obtained because mesio-distal width is less than the labiolingual width. Okay, therefore he said that absence of rotation is very important to have a normal occlusion so that there is good intercuspation. All the rotations have to be corrected. So this is one thing which can be asked in your MCQ. When you derotate a lateral incisor. Suppose the question is, if you derotate a upper lateral incisor, what happens? Do you get space or do you need space? So the answer is we need space. And explanation, mesiodistal width of upper lateral incisor is more than the labiolingual width. Okay. Next situation, your lower second premolar. Note, your lower second premolar is rotated. Suppose it is mesiobuccally rotated. Okay. So if you want to derotate a lower second premolar, will you get space or do you need space to correct the rotation? The answer is we will get space after we correct the rotation. After we derotate the second premolar, we will get space in the arch, right? Moving on, the next thing he told was tight contacts. He emphasized the importance of tight contacts in good occlusion. Okay, for the upper and lower arch to be in good intercuspation, to have a good occlusion, there should be tight contacts among teeth. You do not have scope for such kind of spaces. What are the disadvantages of this space, first thing, and what does it denote, right? Disadvantages. First, aesthetics. It does not look good. It is not aesthetic enough, right? Second thing, there can be food lodgement. And if there is food lodgement, it can lead to dental caries, it can lead to gingival recession, swelling in the gingival region, and all your periodontal problems, right? So this is the problem if we do not have tight contacts, right? And absence of tight contacts, what does it indicate? It indicates Bolton's discrepancy. You all must have done Bolton's analysis. Okay, so presence or absence of crowding or spacing is indicative of Bolton's discrepancy. See, basically what happens? There is tooth material arch length discrepancy, right? If my arch is small, teeth size is big, it leads to crowding. If my arch size is big and my mesiodistal width or my tooth size is small, it leads to spacing. And all this is what this, to measure this discrepancy, we have Bolton giving us formulas. Okay, so we follow the formula given by Bolton's and we analyze how much spacing is there, how much crowding is there, where is crowding, where is spacing. Okay, so all the analysis is done by Bolton's. Therefore, he told all such space or Bolton's analysis should be done so that we know how much space is available in upper and lower arch and how to get it corrected, right? Therefore, he told that such things should be avoided and post-treatment all teeth should be in absolute tight contacts. See, there is absolutely no spaces here and there are tight contacts. It will not only give you an excellent occlusion, it will also give you good aesthetics, plus good oral hygiene can be maintained easily by the patient, right? So these were the 6 keys of occlusion given by, this was the 5th key of occlusion which was given by Andrews. Moving on to the last key which he gave, it was the curve of Spee. You all must have heard about curve of Spee, maybe more in prostho, right? So first thing, what is curve of Spee? Curve of Spee is an anteroposterior curve which is drawn or traced by touching the buccal cusp of posterior teeth, moving ahead and touching the incisal, moving anteriorly and touching the incisal edges of lower teeth. So this curve which you get is known as the curve of Spee. Sorry. According to Andrews, 1.5 mm curve of Spee is considered normal. Okay, if your curve of Spee is 1.5 mm, it is normal. You need not correct it. In case my curve of Spee is excessive, that is more than 1.5 mm. Anything which is more than 1.5 mm comes under the category of excessive curve of Spee. There is nothing like more curve of Spee, enlarged curve of Spee. The terminology is excessive. Please be very much thorough with such terms. You cannot use lousy terms like curve of Spee is more, it is increased or anything. It is excessive. So anything which is more than 1.5 mm is indicative of your excessive curve of Spee. Excessive curve of Spee means it is going this way. Okay, excessive curve of Spee is denoted this way. So when my curve of Spee is excessive, there cannot be good intercuspation. By chance, now let us consider the next situation. If my curve of Spee is less than 1.5, maybe if it goes in negative, suppose -2, it is indicative of reverse curve of Spee. It means suppose my molar and premolar, they are protruded outside, they are extruded. So it will give me this kind of a curve. So this is known as a reverse curve of Spee. These are the two terminologies. Curve of Spee can either be normal, it can be excessive, or it can be reversed. We have to keep it normal. If it is excessive or it is reversed, we cannot have a normal proper occlusion. Okay, till 1.5 mm it is fine, but anything above and way below it is not normal. It has to be corrected. And how can we correct a curve of Spee? If from the figure you can make out, if this is the horizontal line, right? If you want to correct the curve of Spee, either you extrude your posterior teeth or intrude your anterior teeth. Correct? Next question which can be asked in your, which might have been asked in your Viva during your BDS times, or maybe it might be, if anybody can ask you, how do you measure the curve of Spee? Okay, there is always good methods where you use a brass wire, you can measure your curve of Spee. Okay, but if there is a situation where you just have a cast, so how do you measure it? First thing, curve of Spee is never measured in patient's mouth intraorally. It has to be always measured on a cast or on a study model. First thing. Second, how you can do it is just place a ruler on the lower model or the lower cast. It should touch the posterior teeth as well as the anterior teeth. Okay, so the vertical distance which you get, if suppose this is your ruler, this is the teeth, this vertical distance which you get is your curve of Spee. Okay, so you can measure it, how much is the vertical distance, so you know your curve of Spee. In case it is 7, what does it indicate? It is excessive curve of Spee. So how do you correct a curve of Spee? Curve of Spee can be corrected either by extrusion of posterior teeth or intrusion of lower anterior teeth, or it could be a combination as well, depending where the problem lies. So a lot of analysis are there to find out how to correct a curve of Spee, whether you should extrude, intrude, or a combination method has to be done. But for you at this level, what you should know, the sixth key given by Andrews is the curve of Spee, which is an anteroposterior curve running from posterior teeth to anterior teeth. How do you trace it? It is always traced in a cast or on a study model, okay, by touching the buccal cusp and the incisal edges of anterior teeth. The normal value is 1.5. Anything above that is excessive. Anything below that indicates your reverse curve of Spee. And how do you correct it? Either by extrusion of posterior teeth, intrusion of anterior teeth, or a combination method. Okay, what did Andrews say? He said that curve of Spee should be normal. It should be close to 1.5, 0.2 to 0.5 millimeters here and there is fine. But if you want a normal occlusion, if you want a good intercuspation, curve of Spee should be in that limit. Right? So this was 6 keys given by Andrews, but that was not it. Okay, there were many researches which were going on, a lot of people doing researches. Researches are something which goes on, right? Everybody keeps doing that. So based on one such research came the 7th key. We have 7th key which can be asked in your exam. It can be asked as an MCQ. How many keys are there? So you should know now there are 7 keys of occlusion, and the 7th key is your Bolton's tooth size ratio. This is the name of your 7th key. Next question. Who gave the 7th key? Was it given by Andrews? No. The 7th key of occlusion was not given by Andrews. It was given by legendary McLaughlin and Bennett. McLaughlin and Bennett, they have an immense contribution in orthodontics, right? And one of the major contribution which they have made is giving the 7th key of occlusion, which is the Bolton's tooth size ratio. So you all know what is Bolton's analysis, what is Bolton's ratio. What is done is upper and lower teeth Bolton's is calculated. We should know what is the Bolton's error, whether there is excessive tooth material or there is excessive space in the arch. If the tooth material is excessive, it will lead to crowding. If the tooth material is less and arch length is more, it will lead to spacing. So what is there? In both the figures, you can appreciate that there is upper and lower anterior crowding. Why? Because the tooth size and the arch length, they do not match together. So because of Bolton's analysis, we get to know where does the problem lie, whether the problem is in maxilla, whether the problem is in mandible. Once you know the problem is in mandible, suppose next question, where is it, anteriorly or posteriorly? So Bolton's is the answer. Bolton will give you all the answers. He has done excessive work. You have Bolton's analysis, Bolton's formula, which will tell you exactly where the problem is. So from here, maybe we can make out the problem lies in lower anterior region. Now, how much is the problem? It gives you numbers as well. Maybe the discrepancy here is of 3 to 4 millimeters. Because of 3 to 4 discrepancy, there is lower anterior crowding. So that is how we decide the treatment plan of the patient. Before deciding on to go for extractions, whether we have to go for closure of space, what has to be done, stripping has to be done, expansion has to be done, how to gain space in the arch, we need to know Bolton's tooth size ratio. We need to do this analysis so that we know exactly where the problem lies and how much is the problem. Okay, so students, please note that there are 7 keys of occlusion now. 7th key was not given by Andrews, it is given by McLaughlin and Bennett, and the 7th key is Bolton's tooth size ratio. Okay, because of the Bolton's tooth size ratio, you can know where the problem is, how much is the problem, and accordingly a treatment plan can be taken into consideration. So with this, I hope Andrew's 6 keys of occlusion and the 7th key is very much clear with you people. So it was given by Andrews in 1972. First is molar interarch relationship, where he told about class 1 relation, where we consider mesio-buccal cusp, mesio-lingual cusp, as well as the distal marginal ridge. Next was mesio-distal crown angulation. It is done by drawing a line through the long axis of the crown, right, and perpendicular line is drawn to the occlusal plane, and then we know how much it is. Next is labiolingual crown inclination, which is also known as torque. It can be positive or negative depending whether the crown is labially placed or lingually placed. Next thing he told was absence of rotation. Absence of rotation is important to get good intercuspation. If my anterior tooth is rotated, you need space in the arch, and if my posterior tooth is rotated, we get space in the arch after correction of the rotation. Next thing highlighted by him was importance of tight contacts. Okay, tight contacts will give you proper, normal, good occlusion plus aesthetics and no oral hygiene problem. The last thing he told was curve of P, which is an anteroposterior curve, normal values 1.5. It can be either excessive or it can be reversed, and I have mentioned different ways of correcting it. The last key is your 7th key, which is Bolton's tooth size ratio, and it was given by McLaughlin and Bennett. This is very, very important, students. Please be very much thorough with this. You should know the 7th key of occlusion, right? So I hope this lecture is very much clear to you. This was one of the most basic topics which we have, Andrew's 6 keys of occlusion. I have tried to incorporate few more things here and there so that in general also your knowledge increases. We'll be coming up with a lot more of lectures, few MCQs as well, and I hope these lectures are useful for you. They'll help you in preparation for your NEET MDS examinations. Even if you're a BDS student, you can of course go through these videos. Even MDS students can have a quick revision by going through these videos. So like, comment, subscribe to my channel. If there is any query, please feel free to drop in a comment. I'll definitely revert back. Subscribe my channel so that you get a notification whenever I'm uploading a new video. Right, so all the best students for the preparations. I hope these things are useful for you. Please feel free to get back to me in the comment section below if there is absolutely any query. Thank you so much and have a great day. Looking forward to many more interactions with you people. Thank you.